Okay, is everyone ready for me to start then? My name's Andrea. I'm an F1 who's currently working in the AMU department, which is Ward J26. And Rena's going to do this talk with me.
Yeah, I'm currently working on elderly, so I'm the F1 engineer, and I've done gen med and currently doing elderly.
So prior to working on the AMU, I was doing elderly psychiatry. And basically, when I looked at the list of stuff that's to be covered for you guys in your mental health block, it's absolutely enormous. And I kind of thought, well, you've got that list, that's a great revision list, and I didn't have any sort of access to that kind of list when I was studying. So basically, that list was pretty impressive, and if you cover all that stuff, you'll have covered everything. But what I wanted to talk about today was perhaps just some things that were useful to you when you start work. They are relevant for your exams, I think, but they're probably slightly more relevant for when you start work. But you can see what you think, and if there's anything sort of more exam related that you want to ask at the end or whenever, just feel free. So basically, I was trying to aim for that intersection, right? And I'm not sure if I've not gone too far that way, but it's all useful, and it'll definitely be useful when you start work. So I've just covered 4 things, basically, because mental health is huge, and I didn't really see the point of trying to, discuss dementia, depression in half an hour. I've covered paracetamol overdose. All of this is quite kind of light on theory. It's just the kind of principles in your mind, so that when you start work, you are in the sort of habit of thinking, I need to do this, this, and this, and that's. You can look up amounts, you can look up doses, you can look up kind of quantities and stuff when you start, but it's just that I need to think about 2 important things with this kind of patient. The principles are like the most important thing. If you've got the ideas straight, you'll work out the logistics of amounts and doses and timings later. So basically, paracetamol overdoses. On AMU, which covers like Ward J26 and J29, any day of the week you will see 2, maybe 3, 4 of these on the ward at one time. And what amazed me was how little paracetamol it takes to actually cause quite significant damage. So what I've done here on this slide is basically I've listed out what, in an ideal world, this is what would be done at each hour for someone that's taken a paracetamol overdose. So say someone comes in having taken a paracetamol overdose at midnight. Ideally, you want to get a blood paracetamol level 4 hours or more after that. So if someone comes in at midnight having taken 10 grams of paracetamol, there's no point taking a blood at 1 o'clock or 2 o'clock, really, because obviously it's not hit the system yet. And if you look in the BNF, when you're treating someone who's had a paracetamol overdose, it gives you this kind of curve, which kind of lists off the time after overdose against whether or not the blood paracetamol level, and that will dictate whether or not you treat them.
Well, yeah, I don't think we've included actually that, but as you start on the trust guidelines and in the BNF, you'll have that curve, which basically identifies the most important thing when a patient comes in, as Andrea said, is just find out when was the dose taken. Like, try to figure out, some patients will be able to tell you, some others won't be able to communicate or won't tell you, but try to get an approximate time, because this is going to help you, and where the approximate dose was taken, this is going to help you identify on the chart whether basically we're looking at late presentation or early presentation, and identify on the chart high-risk patients versus non-high-risk patients. So you've got that on your charts and on the trust, so I don't think I'm including it in this slide. It really is in the BNF. So if you just have a look there.
And the other thing is people come in having taken what's called staggered overdoses. So basically you could get somebody who's had non-intentional overdose, maybe they've had toothache or something, and for 3 or 4 days before they've come in, they've taken absolutely tons of painkillers. They didn't realise what they were doing, but they basically then had some like nausea, vomiting, a bit of pain, they've come in, and it turns out they've taken like virtually suicidal levels. With those kind of overdoses, at the paracetamol level, you still would take it, but you're basically going to treat them whatever, because you have no idea what's going on there in terms of how much they've taken and how much damage they've done. And then basically the treatment, the Paravolex treatment, which is the N-acetylcysteine, you get like a pro forma to dictate how much you need to give them, but you give 3 bags. First bag you give over an hour, second bag over 4 hours, and the next bag over 16 hours. So that's just 3 bags, 1, 4, and 16-hour bags. And then at some point, just before the 16-hour bag's going to finish, so maybe an hour or 2 before the 16-hour bag's going to finish, you need to take some bloods. And what that does is, it means that at the time that the last bag has finished, you've got a set of blood results, which kind of will indicate whether or not that patient's still at risk of having liver damage, whether or not they need to have another bag of Paravolex after that, because you can continue giving Paravolex again and again and again, basically. It's not a risky thing to give. It's just that if you can time it so that you're finishing the 16-hour bag and you get these blood results back, that's really useful. It just means you sort of guide your treatment.
Yeah, so basically the blood tests are normal, especially obviously clotting and LFTs. You won't get that patient, will let that patient go home. So it's really important that you check first basically 3 bags of Paralex. You reassess the patient with your seniors, and then obviously, but it's important to just to flag up if the blood results are normal, chase them, because it means he might need another bag or will be fit to go home, in which case, you know, that's different discharge, but it's really important to keep an eye and chase those bloods and do them. So
basically on this timeline, if you have in your mind that someone comes in with a fairly standard overdose and you're pretty sure the time they took it, you're looking at a minimum kind of 25-hour cycle. If everything works out nicely, obviously, you know, you'll be waiting for blood results when they first come in, they'll be in A&E and it won't work out like that. But in your mind, when you start work, if you're just aware of how it operates in terms of the number of bags and when you need to be taking bloods. So blood when they first come in, if it's after 4 hours, and blood approximately to time getting the results with finishing the 3rd bag. That's really useful. The thing with paracetamol overdoses is obviously a lot of people, it's a cry for help, and they will be honest about what they've done because they actually want the attention, so they want to shock you and they want to upset, you know, people in their family maybe. But a lot of people actually don't realise they've done it, or they've done it seriously and don't want to tell you when they took it or how much they took. Basically, if there's any doubt, you just start the N-acetylcysteine. It's not, like I said, it's not a particularly risky thing to give people, so any doubt, just start it, it's not a big problem. And then just monitor bloods, you need to monitor liver function, clotting, they're like really important ones. And then signs and symptoms are a little bit kind of nondescript, some of them, it's kind of pain, maybe around this kind of area, maybe a bit of nausea, but a lot of the time it's not massively
specific, yeah, abdominal discomfort, sometimes with vomiting, but sometimes really not much to give you. So.
And if someone comes in, you know, completely out of it and you've no idea what's going on, it's always worth including paracetamol level with your first set of bloods. I mean, a lot of these will have been done in A&E, so it might not be, if you've got an A&E job, then you need to think about it. But if they've moved up to like the acute medical ward, again, it's still worth thinking about taking it if it hasn't already been done. And liver transplant, basically, if you've got someone whose clotting has gone off or whose liver function tests are looking really quite scary, and by scary, I mean anything over double kind of upper limit. So I think for the ALT when it's anything over about 80, you'd start getting gastro involved, at least make gastro aware of this patient, because I've seen somebody who was 16 years of age who'd basically taken, her mum and dad had gone on holiday and she'd split up with a boyfriend, taken a load of pills, not specifically to kill herself, just to, you know, make her boyfriend worry. And she did herself so much damage that they were querying whether or not she needed to have a liver transplant. So we were kind of like trying to get her to phone her parents on holiday and come back and get them to come back and sort of discuss this liver transplant situation. So I think she was absolutely, she couldn't believe what she'd done, but in the end she didn't need it. But that's how serious it can get quite quickly, especially in younger patients or patients who are going to be liable to be affected by paracetamol quite quickly, like drinkers and people who are on other drugs that potentiate the problem. So we dealt with paracetamol. Opiates, I've seen this a few times on the wards. Like, I've not seen that many patients come into AMU with an opiate overdose, but I've seen it quite a lot when I've been doing like ward cover at the weekend. It's us that are doing it a lot of the time with our pain relief.
So what do you think, I mean, what can cause opiate overdose other than taking opioids on your own, on the ward setting, in the hospital?
That's a massive one, definitely a massive one, is the patches.
Not only patches, but any pain relief which is given to the patient, because obviously if we give a normal dose, regular dose, and then we add a PRN doses like Oramorph or anything, so whatever we give, like always look up, and basically on the ward setting, as you said, like you don't see it quite often unless you work in A&E on admissions unit, but most frequently in a daily job you see it on the ward job, covering on calls and patients who are treated just basically who are just receiving pain relief. So this is a big dose, and the treatment is the same, and we'll go into the signs and some common signs and treatment now.
I mean, I had one experience where the nurse, I was covering like the Gledhow wards at the weekend, so you're completely up to your eyes with it, and really unless a nurse comes up to you and gives you something specific and urgent, you kind of try and avoid getting involved with whatever the problem is. But this nurse just kept saying the patient seemed a bit sleepy, the family thought he seemed a bit sleepy, and I thought, well, it's a hospital, you know, people sleep in hospitals. That's, you know, I really wasn't interested, that sounds awful, but I really wasn't. I wasn't allergic to it at all. And then she said to me, she basically did my work for me and said he's had loads and loads of painkillers. Do you think he might be opiate, like, toxic? And I suddenly went, yeah, I think he might be opiate toxic, I'll just come and check him out. And honestly, I was so scared because I thought I could have completely left him without realising what the situation was. And nurses are your absolute best friends on those kind of shifts. Basically do half your job for you because they often know what the problem is. But it's just something to be really aware of. Anyone who just seems to be getting more and more drowsy, the family say they're not responsive.
What would you be looking when you suspect opioid Toxicity. What signs would you be looking for on a patient?
Pinpoint pupils.
Yeah. Something else?
Yeah.
Okay. What else can opiates cause in a patient?
Radicalized.
Yeah. Something common as well? Confusion? Delirium? Hallucination sometimes? We're talking about accumulation and elderly, but acutely, you're right, you'll be looking for pinpoint pupils because it's very quick to look in a patient. You come in a setting, you need to assess, you don't know, like you see whether a patient's confused, drowsy, GCS drop, and you look at the pupils because it's something you can do very quickly.
Yeah, I think the point about the patch that the girl made over there, that was a great point. Like, anybody who's come in with things like chronic arthritis or those kind of conditions, a lot of them will have a patch secreted somewhere about their person, unless you know that patient. If you're doing ward cover at the weekends, you won't know any of the patients. And anytime you're thinking about opiates, think patches. It's really important because they can just whipped off straight away, and that's half the problem dealt with. But apart from that, you then, if you're really quite worried about them, you can give them the naloxone. Again, I don't want to get too specific with the numbers because you'll have to look it up at the time anyway, and it just sort of depends how much they've had and how sleepy they are. But basically, you can give them a little shot IV and just see how they sort of come around after it. But it reverses, it sort of wears off very quickly, so you can't just give them a little bit, bring them back round a bit, and then leave them. You really need to sort of keep reassessing them every few minutes, really. You can't really leave them for too long.
Because the half-life is very short of naloxone, so you need to be constantly there, whereas, for example, in which patient, for example, do we have like difficult elimination or accumulation? Can we have accumulation of opiates? That's something to look up for as well.
Renal failure.
Yeah, so specifically like in elderly, a patient with CKD, renal failure, they won't eliminate opiates that quickly, so the toxicity will come with lower doses, and it might take a while. So as naloxone weans off and the half-life is pretty short compared to the accumulated opioids in the blood, that's something you might consider giving a few doses at 10 to 20 minutes interval, depending on the patient, up to 10 milligrams. But as you said, the doses don't matter as long as you look up on give a start dose and then you titrate up as per need. It's only based on the individual patient.
Do you ever put it on a syringe drive?
No, there's only, you just give an IV for a cannula, so that, because you're in an acute situation, you're going to have a patient with a syringe driver, and you just give 2 milligrams per vein if available, which is most of the case. You just flush it through, and that's how you give it.
I think the question was, can you give it through a syringe drive? I think there is stuff for giving an infusion. I haven't personally given an infusion. The patient that I saw like this just gave little bursts to, and it kind of got us to where we needed to be. I haven't had to give an infusion myself. I think you can give an infusion over some time.
What happens if you give too much naloxone?
They basically, obviously it reverses the pain relief as well. They will come round and they'll be alert, then they'll obviously be in agony. That's another thing just to consider at the back of your mind, is that what we're going to do when they come round and they're in agony.
If you were to make a really big mistake and give them a massive dose, is there any adverse effects from naloxone?
That's a good question. Are there any adverse effects from naloxone? Actually, I don't know. Truth be told, I've only had to do it once or twice, and you just do it very carefully. You just do little tiny increments.
Basically, it's exacerbating everything you're trying to fight. So if you're fighting and if you're giving opioids for pain, as you said, it will exacerbate pain, make the patient confused, agitated, feel unwell on waking up. But 10 milligrams, and even on the wards, nurses, everyone knows the dose to give, so it wouldn't go jump ever for 10 to 20, because it's something you tailor to the patient reaction. Yeah. So you observe the patient closely, give one dose and monitor for reaction, and then you tailor the dose to basically the patient's response. So you're never going to jump with 10 or 20 milligrams or 50 giving a patient. You start slowly and see, and you should basically stop when the patient, comes around and he becomes responsive. But it doesn't mean stopping there. It means that, we can start assessing the patient, but still needs monitoring in the future. So never jump. Start at a lower dose and monitor closely. But you're unlikely to give. Yeah.
So you should all, that's like the first question, well, not the first question, but definitely a question you should have when you're giving anything like this. If you're not sure what the maximum is or what its effects are, if you give too much, you need to just have a quick look in the BNF, which I should have done prior to this. But to be honest, like we said, you just give it in such small increments that I think there probably is a max amount you can give. But
the recommended maximum dose is 10 milligrams, but you're very unlikely
to hit that. Yeah. So alcohol. The reason I sort of wanted to pick out about alcohol is there's such a vulnerable group of patients, especially on the acute medical wards. I didn't really do this from a psychiatric point of view. I did it from more of a acute medical point of view because they are vulnerable, and also they can be really quite ill if they're not treated quickly. So with the binge drinkers, obviously if a youngish person's coming after an absolutely massive night on beers, because alcohol is a depressant, what you're worried about there is respiratory depression. So it's about A, B, C, D, E and supportive management. I wasn't going to sort of concentrate on that. I was kind of thinking more about the chronic drinkers, but I don't know. I mean, usually when people come up to AMU having had a massive night of drinking, it's just monitoring really. It's just kind of supporting, maybe some oxygen, but most of the time you just sleep it off. You usually have to do things like ABGs, just make sure that they're breathing enough. If they're vomiting and anything like that, you need to make sure they're safe, obviously, from that perspective. But if it's a binge drinking episode, that wasn't really the one I wanted to focus on. I wanted to focus on more the chronic drinkers, because you see these on wards like the AMU all the time. There'll be 2 or 3 on the ward at any given day. And the reason they are so vulnerable and such a problem for us is that alcohol withdrawal, they might have come in with alcohol withdrawal, that might have been the sort of presenting complaint. They might have gone a couple of days without alcohol because they ran out of money or just because they wanted to stop, and then they started having seizures, and then they've come in with a head injury or a seizure. Or they could come to the ward for a completely different reason, but obviously whilst they're on the ward they're not drinking and they're going to go into withdrawal whilst they're on the ward, which is really dangerous as well. And basically the problem is that their bodies have just completely adapted to the depressive effects of the alcohol, so much so that when you stop it, it is like an adrenergic storm, so it leads to all the kind of effects, racing heart, sweaty, palpitations, they feel terrible, they look terrible, and also then it causes neuronal kind of excitatory effects, and it can cause the fitting. So obviously there's a spectrum of severity, and at the very severe end you've got the DTs, the delirium tremens, which is actually like an emergency situation. You really need to not get in that situation when you start work. And I've never seen it on the ward because it's almost standard now. It's almost standard for any patient that comes in with any kind of drinking history, even if it doesn't sound like it's that big a prominent part of their history. It's an important part of the medical history to get, because somebody coming into hospital who drinks a fair bit at home every single night, if they're on a hospital ward for 3 or 4 days and not drinking, you can still get these effects. It might not be to the same extent, but it can make them quite ill.
And always remember, patient underestimates their alcohol intake. So that's something to take into account. If they say 2 units per day, always add a few more when you're looking at chronic consumption, and something to obviously, just keep an eye. And we all underestimate whatever consumption usually when asked by a doctor, so bear that in mind.
And so for paracetamol overdoses, you give Parvolex. In chronic drinkers, boozers, you give Pabrinex. And I'm only stressing this because it took me ages to work out which was which. That sounds awful, but if you're not actually using and prescribing before, it can be really confusing. The other thing with boozers, not to use the term like a derogatory term, but it's just a way of remembering the words. With boozers, you want 2 things. You want Librium and Pabrinex. If you just remember those 2 B kind of words, then that'll sort you out on AMU. Basically, you want to stop them having fits, and you want to sort of stop them having the horrible jittery effects of the alcohol withdrawal, and that's the chlorodiazepam epoxide, the Librium. How you give that on the ward depends on how much they sort of suffer the effects of withdrawing from the alcohol. It's not kind of an exact science, but basically there's kind of ways of prescribing it. Usually given 4 doses a day, maybe 20 milligrams 4 times a day, and then some PRN as well, which the nurses can give if they still seem to be withdrawing. But this is really important, because this is what will stop them having horrible seizures on the ward. I mean, you really just, anyone with any sort of drinking history, insignificant, significant, whatever, just think about the Librium. It's really, really important. Even if someone just has, a generous glass of wine every evening, you could put it PRN, and then if they look a bit sweaty and a bit shaky, the nurse can give it to them. It just makes life a lot easier for them and for us, and it means you're avoiding the horrible situation of alcohol withdrawal fits on a medical ward, which is just not a good place to be. So we discussed the Librium for the boozers. The other thing you want to remember for the boozers is the B vitamins, and this is where the Pabrinex comes in. So basically, Pabrinex, it's not really a treatment. Like someone on the ward the other day was discussing whether or not we needed to give this to a patient because he was he in withdrawal or was he not in withdrawal. It's not really about withdrawal from alcohol. It's about a sort of a treatment of
long-term protection as well, long-term prevention of getting the side effects. Which are the side effects, for example, of long-term alcohol consumption?
Liver failure.
Yeah, some of them are written on the slide.
Yeah, I'm really lazy and like I'm not.
It's not more side effects. It's what happens in a long-term alcohol consumption.
Yeah, like dementia.
Yeah, basically we can get brain damage and encephalopathy, and which is basically long-term condition linked to chronic alcohol consumption. So giving vitamin B and vitamin B complexes as usually we give them if we can as we come to Paracetamol, we'll explain that a bit later. But it is a long-term prevention and long-term treatment as well. Because when given a certain amount of time, it can also have some treatment effects, improving cognitive function in those patients. So we're just gonna go through that.
So basically, because of the B vitamin, especially B1 vitamin deficiency for people who drink significant amounts, there's like a spectrum of neuronal kind of damage that can occur. And the two things to remember, they both kind of come from the same problem, a vitamin B1 deficiency, but you've got Wernicke's, which is severe and acute, but can be reversible, and is reversible in most cases. And at the other end of the spectrum, a bit further on in time, you've got Korsakoff syndrome, which is kind of like a long-term effect of having had a Wernicke's encephalopathy. And basically, if someone's got Korsakoff syndrome, that is bad news. So quite often people will come in, and you'll see from when they come in from the GP, they'll already be on, maybe if there's someone that's known to drink a significant amount, the GP, if they've been aware of this, will already probably have them on oral thiamine and B complexes, which is helpful. But if someone comes into hospital and they're either a massive drinker, or they've just had some kind of event that's precipitated a B1 deficiency, it's sort of a bit unclear how it can happen before they come in, but basically, if something is suddenly manifested in this B1 deficiency, to bring on a Wernicke's, you need IV B vitamins. So in Paracetamol, which is a really nice, you've got your B vitamins and your C vitamins, and that's all it is. And it's basically really, really very safe to give. It can cause a bit of a reaction in some patients, a very small number, but just keep an eye on patients when they start on the Paracetamol. But you basically pile in there with the Paracetamol when someone comes into hospital with anything to do with Wernicke's encephalopathy. But also, even if you just think they might be at risk of an encephalopathy, just pile in there with the Paracetamol. And you have to play very safe with the patients who are big drinkers, because if things go wrong for them, they go really badly wrong, and it's just, a lot of it is reversible quite easily, because these two things, the Paracetamol and the Librium, are dead easy to give. They're not particularly dangerous, and they're not particularly sort of hassly to give, and they only need them, you know, the Paracetamol is usually only like a 3-day course if they're in hospital. But just in the front of your mind, when someone comes in with alcohol, no matter what they're in for, any kind of alcohol history, just think of those two things are really, really important. If you think they don't drink a huge amount, but there's a significant amount there, but they probably eat quite well as well, they look sort of reasonably well kept, you can still put down a kind of a prophylactic dose of Paracetamol, or you can just give them the oral B vitamins and thiamine. But the Paracetamol is the most efficient way of getting them the B vitamins if you think they're going to either start with the encephalopathy or already have it. And basically, Paracetamol is a really strange drug to prescribe because it comes in little glass bottles, and they're called 1 and 2, so you have to sort of prescribe it as payers of bottles. It's a bit strange to prescribe. The first time I prescribed it, I had to ask the nurse about 4 times, how do I write this? And it's a bit odd, but if you just remember Paracetamol, it's that really orangey, yellowy looking one, because it's got loads of nice C and B vitamins in it. It looks like a rocker, basically. 2 little glass bottles, when you start work. It doesn't matter, like I said, about worrying about how you write these things, you'll sort that out on day 1. Just remember that you need to think about those 2 things for people that have a significant drinking history, and that'll make you a really good doctor on M&E, because if that's been sorted out, it's so good for the patients, and it's much better than leaving it until they actually start fitting on the ward, or having an encephalopathy, which then becomes Korsakoff later on, basically ruins their life. Any questions at this point?
What do you think about caution regarding glucose?
Oh, basically, the problem with these patients is they're poor diet. So if you think there's loads of groups of patients who've had a poor diet, and whenever you start refeeding them, you need to be really, really careful because of the electrolyte disturbances. So if you've got someone who's anorexic, for example, or someone who is maybe a chronic psychiatric patient who's not been eating properly for a long time, or someone who's not been eating properly for a long time because they've been drinking, anybody that looks like they've not been eating properly, be very careful what you give them in terms of sugar and food, basically because of the refeeding syndrome kind of situation. But specifically in this case, giving glucose before you give the B vitamins can precipitate the B1 deficiency. I don't know the whole ins and outs of the metabolism, but basically the B1 is used in the when you start giving glucose again, B1 is used up in that process of breaking it down or using it. And so if they've only just about got enough B1, just enough B1 to stop them having Wernicke's encephalopathy, then you give them a load of sugar, a load of cereal and toast like they get on the ward. That can precipitate them a Wernicke's encephalopathy. But if you've been a really good doctor and already given them their Pabranex and their Librium, this isn't a big issue. But you must give the Pabranex first, because if you remember as well, people that come in with sort of chronic alcohol problems, if you don't do it as soon as they come in, it gets left to the ward round, and by the time the ward round's been done, they've had their cereal, they've had their toast, they've had their sugary coffee, and they're already at the stage where they're at risk of something going a bit wrong. And bearing in mind the risk of giving Pabranex and the risk of giving Librium, which is low, it's just so easy to do. And if you all sort of get that message from this lecture, I'll be really happy, because it's just really important to think about these patients. Are so vulnerable anyway, and they're not the kind of patients that people are massively kind of warming to as a rule anyway, because they can be quite difficult sometimes.
Yeah, and another thing to add, why am I looking for glucose? Because any alcohol consumption, especially chronic or acute, can cause is affecting the liver. So basically, those patients are very likely to have a hypoglycemic episodes than any others. They're also more likely to have hypothermia. But here, what we focus on is the glucose metabolism. So they are more likely to be prone to having hypoglycemic episode due to the alcohol and liver damage, basically. So that's why you look up for glucose and monitor closely. And as Andrea said as well, that most of the time they're malnourished or basically decreased oral intake due to alcohol intake. There's less food as well, which makes them more prone to hypoglycemia as well.
Basically, just as a general rule, you'll get loads of talks when you start work from dietitians, but anyone who hasn't been eating properly for a sustained period of time, just be wary when they're on the wards and they start having food again, proper amounts of food. You need to just make sure that magnesium and phosphate and stuff. And as soon as you start work, you'll become aware of it, but especially in these patients.
Sorry, I was a little bit confused. When someone comes in and they've not got any sort of signs of alcohol withdrawal, but they drink a lot, do you give them thiamine and peroxide?
Yeah, because basically you've got two separate issues. You've got the kind of the symptoms of the alcohol withdrawal that are making you shaky, making your heart race, and then possibly making you fit.
No, I mean they're not having that. They're just drinking a lot. Say if they're having a pancreatitis and then no drinking.
Yeah, look, this is what I'm saying. This is why it's so important to take a really good alcohol history, because yes, somebody can come in with the symptoms of having had an alcohol problem, and you'll be totally hot on it, and you'll know they'll need all this stuff. But people can just come in as people that drink a substantial amount every day and come in for a completely different reason. If you can get a decent history...
do you prescribe both though, or just one?
Both of them. Yeah, because they're treating different things. So the thiamine, which is part of your Pabranex, that's to stop the Wernicke's encephalopathy, and that's to stop the kind of degeneration of the nerve tissue. And the Librium is for a slightly different reason. That's to stop the fitting and the kind of autonomic problems which can lead to death, basically, because the DTs is actually a medical emergency.
But when you start, you've got a chart, actually, you've got this assessment. So you assess a patient, individual patient, according to his presumed intake, alcohol intake. Is he presenting any signs? So those assessments are, actually the tools are on the trust guidelines. So we're able for an individual patient to tailor to decide whether he needs clonazepam, although most of the time we will prescribe at least a PRN dose to avoid this patient pitting and withdrawing on the ward and being uncomfortable. But this can be assessed for an individual patient, and you have to find those charts and tables actually on the trust guidelines, and you decide on what the most appropriate dose is according to the intake and the damage. So it is tailored. Obviously, a patient who's just had one-off drinking and is not withdrawing, or if that doesn't have side effects, you would maybe just monitor. But here we're talking about chronic or chronic alcohol intake with supposed damage to the nerves. So in which case we need to protect as well with vitamins B. But otherwise a binge drinker on a Friday night, doesn't need obviously the same treatment.
Are there any more questions about that? Those things, because I was going to move to something sort of slightly different now, just to. So that's kind of overdoses and things on the AMU ward. What I want to discuss now is just capacity in the Mental Health Act, because I think this is quite a difficult concept when you're on the wards. What you're actually allowed to do when a patient says they want to leave, or when a patient says they don't want that treatment, you need to sort of be quite sure about where you stand legally in terms of what people are allowed to decide they want to do, what are you allowed to do to somebody against their will. So there's two kind of different streams really. You've got your medical treatments and the psychiatric treatments, and occasionally on a medical ward, something psychiatric will become quickly apparent. And sometimes you can have loads of them actually at the same time on a medical ward. But for most patients that you see on a medical ward, whether or not a patient can accept treatment or decide they want to leave and all this kind of stuff is based on their capacity. I'm sure you already know all this. So if a patient has capacity, and you know how you sort of assess capacity, if a patient has capacity, they can do what they want to do, that's absolutely fine. So quite often the nurses will say, oh, so-and-so in that bed wants to leave, can you assess the capacity? And this happened to, like a couple of weeks ago on the ward, this lady who was in her late 70s, she'd been on the ward with acute exacerbation of COPD. She'd been there for about 4 days, and every day there were kind of suggestions that she could probably go home later that day and then something would change and she'd be kept in for another day. And basically on day 4 she just went absolutely mad. Got a wheelchair, got a walking stick and started shouting and screaming that she wants to leave and demanded that her grandson take her. And her grandson and her husband were kind of trying to make her stay, and the nurse came running to the doctor's office and was like, oh, you need to assess the capacity, she can't leave. And basically capacity, that question is unfinished. You need to assess her capacity to make what decision, because a capacity decision is a specific thing. It's not she has capacity or he doesn't have capacity. So in your mind, if someone says, can you just assess this person's capacity, the first thing you say back to them is to decide what, because there is no global assessment of capacity.
Yeah, that's something you'll be asked to do like almost daily. And 2 things to remember is that anyone can assess capacity. It doesn't have to be a doctor, it can be a nurse, a dietitian, anyone. But most of the time in practice, we will still want a doctor to do it, and you'll have to document it in the notes. But anyone, remember, can assess capacity. It doesn't have to be a psychiatrist, or you don't have to go to psychiatry to assess a patient's capacity. You can do it on your own. And the other thing is capacity is basically time-specific and decision-specific. So if I don't have capacity now at the moment, taking one decision in 10 minutes' time, my capacity might have evolved and changed, and I'd be actually deemed as having capacity 10 minutes later. I mean, usually it doesn't happen 10 minutes later, but time-specific and decision-specific, and can vary on a daily basis.
Mm-hmm. And it's something you need to be kind of on top of if you are on a medical ward where patients are likely to sort of suddenly decide they're going, because that happens all the time on J26, for example. Especially people that have come in with things like alcohol problems, which it just makes it really, really complicated to understand. Can I let them go? Are they allowed to go? Basically, your first port of call is, do they have capacity? And if they don't have capacity, we're allowed to act in their best interests. And best interest doesn't just mean best medical interest, it means best kind of global interest. So you do what's best for that patient, bearing in mind them, their opinions, their life, their background, their setup at home. You've actually got quite a lot of freedom there, but basically, yes, it's going to be medical decisions most of the time. Psychiatric side of things is a bit different. It's not really about capacity in this, well, it's not about capacity, it's also a completely different concept in psychiatry. In psychiatry, if you want to detain a person to the ward, 2 things have to be true. One of them is that they have to have what's defined as a mental disorder, and that's a little bit more wide than a mental illness. We'll talk about that in a second. And the other thing is, I mean, you're allowed to have a mental disorder and leave the ward. It's just if you've got a mental disorder and you're a significant risk to either yourself or to some other person, then you are allowed to section them to the ward. So if those 2 things aren't coexisting, then you can't keep someone for a psychiatric problem on the ward, for a psychiatric treatment, on the ward. So the first thing to think in your mind is, am I trying to get this person to have a medical kind of a treatment or a psychiatric kind of a treatment? And then that sort of guides your decision about what kind of legal basis you're going to be under. I mean, when I was at the Mountain Hospital, which is the elderly psychiatry hospital, we had people there who were sectioned for psychiatric treatments, but we couldn't just give them any medical treatment we wanted, because in some respects they still had capacity to make decisions about their medical treatments. So they're 2 completely different concepts, and they sometimes interlink, and often they don't interlink at all. So first of all, decide, is it a medical treatment that I want this person to have, or I'm advising them to have, or is it, am I worried about a psychiatric condition? If it's a psychiatric condition, do they have significant risk or risk to someone else, and do they have this mental disorder, which is more than just a mental illness? And if they do, you can use the Section 5.2 of the Mental Health Act. If they don't, then you're powerless, they can leave, basically. If it's a medical kind of problem that you're worried about, do they have capacity? If not, this means then you're protected under the Mental Capacity Act, and you can act in their best interests. But the minute you do that, if you're depriving someone of their liberty, you need to fill out quite a lot of paperwork, because basically you're going to then have to keep someone prisoner on the ward effectively, and that requires a safeguarding measure. It's called the DOLS paperwork, which is deprivation of liberty safeguarding. And the Mental Health Act, Section 5.2, kind of has all this integrated within it, so you don't need to bother with that. Once you've assessed that someone's a risk and has a mental disorder, you can keep them on the ward, that's fine. The thing to remember about the medical side and capacity is that if you've decided someone doesn't have capacity, but treating them means you're going to have to kind of restrict them to the ward, you need to fill out this deprivation of liberty safeguarding paperwork quite quickly. The other thing to be really aware of is aggressive patients. Quite often you'll see in the notes things like patient wouldn't let me refuse cannula. Well, every single time you want to treat a patient for something, or take a blood, put in the cannula, give them the paracetamol, you need to assess if they have capacity at that time to make that decision. And if they don't have capacity, really the aggression is neither here nor there. Obviously personal safety is paramount, but you're actually sort of legally on very dodgy ground if you don't act in someone's best interest if they don't have capacity. And this happens all the time at work. People refusing to let them, let you cannulate them. People sort of just being difficult to work with. You need to get a nurse to come and help you. You need to make sure that if they don't have capacity, and therefore you're acting in their best interest, that you act in their best interest and do what needs to be done. Because sometimes I get patients that come in delirious, they don't have capacity, they're absolutely out of it, but they're kicking and screaming. I mean, if you don't pin them down, get a cannula in, get fluids going and antibiotics and whatever else is necessary, then you have actually kind of, you haven't acted in the best interest, and you could actually be sort of liable to sort of further problems legally. And the only reason I say this is that someone I know quite well, she is a solicitor who kind of reviews case notes of people who are suing hospitals, and basically they go through the notes with a fine tooth comb. They get other medical advisors in to look at the notes and say that should have been done, that was inappropriate, and that's how finally they'll go through notes if they think something's not been done properly. And one case she told me about, some young guy had broken his leg, was waiting for an orthopaedic bed, I think, in the meantime was bleeding into his thigh, but nobody kind of realised, and was becoming obviously hypoxic and a bit shocked, but absolutely kicking off, wouldn't let anyone put a cannula in, wouldn't let anyone give him any fluids or blood. And basically in the notes it's just been written about 8 times, fluid refused, cannula refused, patient refused cannula, patient wouldn't let me do this, patient wouldn't let me do that. And in the end he sustained a massive brain injury because he became so hypoxic that he just collapsed on the floor and nearly died. And now he's like severely brain damaged, and all those doctors that wrote patient refused to let me do this are kind of really on dodgy ground because he didn't have capacity. The fact he was aggressive obviously is an issue, you need to make sure that you're not going to get a wallop, but you can't just say, oh, he was aggressive so I didn't do it. You need to be really careful about that. Aggressive is not the same as having capacity to refuse, basically.
If someone's really, really aggressive, then you can't assess their capacity.
Well, the thing is, it's a fine art, I suppose, and it is a totally grey area. And as an F1, I'm not going to decide that I'm going to get security up to pin down a patient's cannula. If it's absolutely necessary, I'll ask the senior first, and I'll say, look, what's going on. You need to. The other thing to be aware of, is the necessity of what you're trying to do. I mean, just checking, giving them a Paracetamol or something. I'm not going to pin someone down to do that. But if somebody with something that isn't right, you need to be really, really careful. I'd rather have assessed someone's capacity and perhaps taken it a little bit too far, got senior review in, and maybe been a bit too proactive than have just said, well, they weren't really interested in how to cannula, so I left them to it, and then they're septic.
So yeah, that's the things you should be aware. I said we should always presume that the patient has capacity until proven otherwise. So even if it sounds crazy to us and wise or whatever, or we can't deprive someone of their liberty or their freedom just because we consider that it doesn't sound really good, a wise decision. The other thing is in real life not on a daily, but very frequently you'll be in situations where you've been first on the line and asked this patient is refusing, this patient is aggressive, what's going on, and you need to take decisions. And as Andrea said, patients who refuse treatments, refuse things done to them, but still, we can't just leave them with saying documenting patient refuse. If the capacity hasn't been assessed, and even though we always need to act in the best interest, which in real life also means sometimes it will take 3 or 4 doctors or 3 or 4 healthcare professionals or nurses to help you around secure help with giving treatment to a patient who doesn't have capacity for whom we're acting in their best interest. So it will sometimes be kind of a physical job as well, restraining a patient in order to give him the treatment he legally and medically needs, actually. So sometimes you'll get into the tricky situations.
You're right, it's a really good point to raise, because I mean, there's those people who are just plainly bonkers and make bonkers decisions. That's absolutely fine, and it's not black and white at all. And you need to just sort of there'll be obvious cases either way, and then the cases in the middle that you have no clue based and you're just not sure. And you can always ask for senior help. It's not a problem. In a kind of an acute situation, if you're really, really worried, I would sort of do what's required to give the best likely medical outcome, I guess, is the advice, just because, in
an emergency situation, no one's going to blame you for acting in patient best interest unless there's something documented legally and the patient has refused, in a legal manner to have something done to them, but always act in patient's best interest in doubt.
So basically, just a very quick overview. The Mental Capacity Act has some principles and then some sort of rules by which you assess someone's capacity. So yeah, you assume someone has capacity, you do everything you can to help them make a decision, you allow them to make what you would think was an unwise decision, that's absolutely fine. Then there's best interest concept, and then you do the least restrictive thing possible. Like we had a patient on the ward the other day who had Down syndrome, I think he was in his 50s, who had a bit of a low BP, and was just absolutely refusing point blank to have a cannula and fluids. This was like in the evening, it was getting on for like midnight. And they'd been prescribed these fluids, and the nurse said, I need to give these fluids or not, what are you going to do? And basically, he probably didn't have sort of capacity, but I felt the least restrictive thing to do was for him to just try and encourage oral intake, just, not to upset him. I don't want to be pinning people down unnecessarily. And to be honest, his BP had been low the whole stay, and I think it was generally just low BP. So, there's a little bit of leeway there to make a decision that's kind of reasonable. I'm not going to get people offside and upset people. If it'd been life and death, obviously I would have done it. But. And then the assessment part, and there's a couple of things on here that are really useful to sort of know. Yes, the patient needs to understand, they need to be able to retain, they need to be able to weigh, and they need to be able to communicate. But quite often you'll have people like young people who seemingly have all these sort of domains covered, but actually it's quite easy to sort of, in certain situations, say they're not really weighing things up properly. They seem to weigh it up, they seem to have expressed their decision, but I'm just not convinced they are weighing it up properly. We'll sort of look at an example of that in a minute, but although these things seem quite clear-cut, they're not actually, there is a little bit of leeway there for saying, I don't actually think that someone does weigh things up properly. So the Mental Health Act, again, just to reiterate, people with a mental health disorder and who pose a substantial risk either to themselves or others, and capacity and kind of mental health concepts are different domains. Sometimes, they overlap and sometimes they don't, but they're different concepts. So you can have a mental disorder, you can be a risk to someone and still have capacity for other things. Just a summary of the differences there. So Mental Health Act, that's when you think somebody's in psychiatric treatment, medical treatment, you're thinking about capacity or not capacity. The Mental Health Act, it automatically includes detaining kind of powers, but the Mental Capacity Act, it allows you to detain somebody, but then you need to fill out further paperwork, the DOLS paperwork. And Mental Capacity Act kind of applies to decisions, minute by minute, hour by hour. And the Mental Health Act, you should only really use that if you're going to get someone to be psychiatrically assessed and treated urgently, and it's the beginning of a process of psychiatric treatment, really. So that's how you should view it. It's not a one-off thing to keep someone on the ward for 2 days to give them a medical treatment. It's part of a psychiatric problem and treatment. Just a very, very quick example so that you've got the concepts clear. 19-year-old, this happens all the time, 19-year-old girl at A&E, taking loads of paracetamol, her friends have brought her in, literally kicking and screaming, fighting people off. Could you get like 4 members of staff to pin her down to take her bloods? And if so, how would you be protected legally from being accused of battery? Yeah. So this is a medical situation. I mean, she might be communicating to you. She doesn't want to have her bloods taken. But actually, you could sort of say, well, in this situation, she's obviously, something emotional has happened. She's obviously emotionally disturbed. I don't think she's weighing stuff up properly. And yeah, it's a medical decision. This would be about capacity. So you just say in this circumstance, she doesn't have capacity to
So you would act in her best interest, but carefully document that what you're doing and that you're acting in her best interest, and that at that moment she didn't have the necessary capacity and a clearness of mind to take the best decision for her.
Next one really quickly. So on the interview, she's calmed down quite a lot. She's totally calm, she's totally reasonable now, speaking to you normally. She's taken out a cannula. She doesn't want another one, even though, the likelihood of her doing some serious liver damage is high, and says she wants to go. can you actually get security up and make her stay on the ward? And if so, how are you protected from being accused of false imprisonment?
Can you use the Mental Health Act in that case to get her assessed for depression?
So I can't see, sorry, I'm like, who's speaking? Yeah, sorry, yeah.
If you use the Mental Health Act, you can people on the ward because obviously it's not like a rational thought.
Yeah. Actually, yes. So the question she said, you can use the Mental Health Act because she sounds sort of like low in mood and everything. I mean, to be honest, you could probably get away with either on this. I was thinking this might be the situation where you say she seems to be conveying her decision, and it seems to be, you know, she's understood, she's retained it, she's weighed it, and she's communicated it back. If someone's very sort of emotionally traumatised, that's your kind of get-out clause on the weighing up. So you might be able to get away with saying, I still don't think she's quite got capacity, but obviously you'd ask a senior to review her as well. Or you could use the mental health. Definitely, if you think she's got a long-standing issue with depression and she's suicidal, you definitely want to get her psychiatrically reviewed. And again, you could use the mental health act probably. So sometimes, you know, it just depends what's going to be easier for you and more appropriate. You'd always run it by your seniors, but probably get away with either on that one. So now she's had everything, the blood's back to normal, she's medically fit. She's been really good on the ward and she's compared everything, but she says she really, you know, she's ready to go home now, but you're not happy with her mood. Would you be able to just say to her, I know we've said you're medically fit, but can you just stay? And if you're not going to stay, we're going to get someone to make you stay. Again, I mean, this is another one. This is the problem with all these situations. As long as you've got some structure, that's all you need, because every situation will be different and it'll be so difficult to work out. I mean, in this, maybe if you're really worried about her mood, again, the Mental Health Act, you might be able to use that here and just, you know, you're going to maybe get someone from psych to assess her and treat her maybe for like really severe depression. You might be able to use the Mental Health Act on that one. I don't think you'd be able to use. Well, you wouldn't be able to use
that case, yeah.
You couldn't use capacity for that one because you're not going to give her any more medical treatment. So Capacity Act applies to the medical side of things, and you really couldn't use it in this situation.
So always encourage patients' own decision making and explain the risk and the benefits. Let them weigh up the decision if they have capacity, but always encourage and allow for wise decisions or what sound to us sometimes we're crazy on sound decisions, but we're all allowed to do it as long as we have capacity. So never presume that we as doctors have all the knowledge and have all the rights to decide. So encourage and explain in patients' own words what basically, so that they are able to reach a decision if they have the capacity.
Any more questions from anybody?